This is Case of the Day. I'm Dr. Bhavin Jankaria, and we've hit three figures now, or rather three digits, not figures. So we're on 101st case, and it's titled MYH7 Dilated Cardiomyopathy and LV Reverse Remodeling. So this 27-year-old presented 2 years ago with a dilated cardiomyopathy. And you can see that here there are elevated end diastolic and systolic volumes. Ejection fraction was about 42%, normal RV function. T1 was mildly elevated 1343 on a 3T scanner, no edema, no late GAD enhancement, and normal T2. So there was mild diffuse interstitial fibrosis, if at all. And so we have an idiopathic non-ischemic dilated cardiomyopathy. And if you remember, case 70 was about Titin or Titan, I don't know how that's pronounced, genetic dilated cardiomyopathy. And I had shown this slide where Titin, Lamin, and then MYH7 are 1, 2, and 3 as the causes of genetic dilated cardiomyopathy. The rule now is that every idiopathic dilated cardiomyopathy must undergo genetic testing, and we actually mentioned this in our reports, though the concepts are still very new and most physicians and cardiologists are not aware of any of this. So that does become a challenge. So the number of people getting tested is small, but this patient got tested, and he was found to have MYH7 likely pathogenic variant, which means that the patient has MYH7 genetic dilated cardiomyopathy. And I had missed this article, so right now when I was searching for more information, I came across this. You've got an entire paper on just MYH7 related dilated cardiomyopathy, and Jack does these central illustrations which are so useful. And so they had 147 patients, 16% had DCM onset under 18, and the LV reverse remodeling rate was considered low at 28%. Which is interesting because we rarely see reverse remodeling in patients, but this patient came yesterday, and I was reading this today, and I saw that the end diastolic and systolic volumes have reduced. There is improved thickening and contractility. So the ejection fraction has gone up only by 1% for a variety of reasons, but basically there's significant improvement of thickening and contractility. So this is LV reverse remodeling, where there is improvement of contractility and function. So to summarize, MYH7 is the third commonest inheritable cause of genetic dilated cardiomyopathy. But more importantly, all idiopathic DCMs must have genetic testing done to determine prognosis. Different genes have an arrhythmogenic and heart failure possibility. So MYH7 is associated with dilated cardiomyopathy and heart failure with a very low rate. In fact, it's mentioned in that central illustration. Just 1% rate of malignant ventricular arrhythmias at 5 years. So these patients would not really go into arrhythmogenic cardiomyopathies, but would go into dilated cardiomyopathies that have a propensity to heart failure. And the third reason is that if this is positive, like in this particular patient, ideally all first degree relatives should be screened to check whether they have the gene or not, and then obviously they need to be then screened with echo and cardiac MR to see whether they have phenotypic expression of the disease or not. That's the seminar on the 5th of October, my WhatsApp channel. Thank you so much for viewing this.